we'll go ahead and get started. I'll turn it over to Michael. And if you haven't yet had a chance to chat in, please continue to enter your name, organization, and the state you're joining from. And Michael, the floor is yours.
Thank you, Meredith, and welcome everyone to today's Telegen Community Connect educational learning session. I'm Michael Boyson. I'm a program specialist for Telegen out of the Colorado office and the chronic disease prevention and management lead for Telegen's Quality Innovation Network Quality Improvement Organization contract with CMS. My role today, however, is to go over several housekeeping items and to get today's session started. And our topic is titled Chronic Disease or Chronic Kidney Disease, Risk Factors, Treatment, and Health Equity. And it's with our panel, and this is part 2. And it's an extension of our March 17 event that was well received by many of you. And we're delighted to have our subject matter experts back with us again. So more about them in a few moments. So let's move on to the next slide. As a reminder, we encourage you to visit our website at telegenqiconnect.com. You can learn a lot about us in terms of who we serve, in terms of our CMS QIN/QIO contract. There's upcoming events, resources, and tools. There's podcasts. You can even learn about our team and gain access to the portal. And speaking of the portal, let's go to the next slide. We encourage you to enroll in our QIO program called QI Connect to gain exclusive access through our portal that includes who we are partnering with in terms of our communities and providers. Some of the community and individual provider data is also available in our portal, as well as we have quality and evidence-based tools and resources to improve health equity and patient care. Now, as a fairly funded contractor, our quality improvement assistance, trainings, and other services are offered at no cost to providers and community-based organizations that choose to join us to improve healthcare quality and reduce healthcare disparities. And our priority areas, just to name a few, include slowing the progression of chronic kidney disease, today's topic, improving control of hypertension and diabetes for Medicare fee-for-service beneficiaries, as well as reducing avoidable readmissions. Enroll with us if these quality goals align with what you're working on now. All right, so let's go to our disclaimer slide. Before we dive into today's topic, we have several things to disclose. Telegen takes all available steps and precautions to provide a secure use of this Zoom conference platform, but we're not responsible for the platform's performance. As with any new treatment guidelines and standards of care, they continue to be involved. They continue to evolve, and today's content and answers to your questions reflect Telegen and our speakers' best understanding based on currently available information. And of course, we encourage you to regularly check for updated CKD standards of care and guidelines with CMS and with your professional associations. The information shared by our subject matter experts are neither endorsed by nor do they necessarily reflect the opinions of Telegen or CMS. Having said that, we certainly like what they are planning to share with you today. And of course, Telegen does not have any financial interest to disclose. These trainings and technical support are offered at no cost to participants because of the QIN/QIO contract. Okay, so let's look at the agenda. So here's our agenda for today. I'm going to go and review our objectives next in a moment here. Then I'll pass it over to my colleague, Dr. Jane Brock, who will tackle our first and foremost section of the call and review some of the key data based on what we're seeing. And for those new, we will then introduce our expert panelists before the panel discussion, followed by a Q&A. Finally, I will close us all out with a call to action and next steps. Now, next slide. In terms of our program objectives, it builds basically on session 1 and continues to center on raising awareness on CKD, focusing in on prevalence, frequency, and distribution among vulnerable populations. And this includes those living in rural and medically underserved areas and those who continue to be impacted by racism and marginalization due to social determinants of health. We also want to continue to explore with our subject matter experts causal factors in inequitable outcomes for chronic kidney disease. We also want to highlight the importance for involving community in understanding CKD risk factors and resources, as well as self-management. And we'll do this by highlighting and promoting emerging and evidence-based CKD practices. Finally, we want to provide an opportunity for you, our participants, to network and share your best CKD practices, as well as evidence-based CKD practices with others. And you can do this in chat, as well as during today's Q&A session. So with that as background, I'm going to turn it over to Jane, our panel facilitator, to get us started. Jane?
Thank you, Michael, and thank you, everyone. Are we okay? Yeah, okay. Thank you for joining this discussion. I'm Jane Brock, and I've been a medical director at Telegen for more than 20 years, working to improve medical care and outcomes and using Medicare data to monitor and improve the health of the communities we work with. So I am personally so motivated by the challenge of better CKD management. Just originally as a person who just pokes through large data sets and does research around sort of priority health conditions. But the situation we're in with CKD is truly astonishing. Not only is it extremely prevalent, but the gaps in ideal screening, diagnosis, management, and outcomes are well, astonishing. So thank you so much for joining us today. And I just want to express my absolute gratitude to today's panel of experts who are joining us today for the second time. So next slide. So today's panel will help us continue the discussion begun in part one of this educational series. We had a very robust discussion and a bunch of kind of crucial unanswered questions at the end of that session and at the end of our original session, which happened in March, that we knew that we had to do a part two. We want to explore the substantial gaps in the racial distribution among people with diagnosed CKD versus end-stage renal disease, and most importantly, suggest strategies for improving outcomes among people with or at risk of CKD to prevent ESRD and eliminate inequities. So next slide. So we have a ton of data, and we would be pleased to share lots of data with whoever would like access to see our data. But this really summarizes what's motivated, well, me and us to collect such an array of experts to discuss the root causes and, more importantly, the potential interventions to address outcomes disparities among people with kidney function decline. So in our entire fee-for-service Medicare population across 4 states, our states are Colorado, Iowa, Illinois, and Oklahoma, the racial distribution of the general Medicare population looks a lot like the distribution of the population that has some degree of diagnosed renal impairment. But when we look at the population with end-stage disease, including those on dialysis, there's just an enormous difference. So Blacks are 10% of the population with kidney disease, but a quarter of the population with end-stage. Hispanic ethnicity is less than 2% of the population with diagnosed kidney disease, but more than 6% of the end-stage population. And for Native Americans, they're about 2% with kidney disease, but more than 3% with end-stage disease. So the trends we are seeing in our state reflect national data showing the elevated risk for kidney disease and kidney disease progression among people of color in the US. So there are many well-known and described challenges in accessing prevention strategies and quality of care for people with early stage disease, which fall disproportionately on people living and or seeking care under disadvantaging circumstances. And we started scratching the surface of those challenges in our first discussion in March. So today we're going to continue that discussion with this really unparalleled panel of experts with a focus on immediate actions that we need to escalate to turn this around. So next slide. I just want to first note that all of these remarkable panelists have extensive resumes that frame a huge depth of expertise and commitment to the issues we are discussing today, but they are attached to the meeting materials. So in the interest of reserving the most possible time to actually hear from them, I'm giving you only the basics as an introduction for our panelists. So first is Dr. Matthew Sinclair, who is a nephrologist and researcher at Duke University. Dr. Sinclair works with patients as a faculty nephrologist at both Duke University Hospital and the Durham Veterans Affairs Medical Center. Dr. Sinclair's research within the Duke Clinical Research Institute focuses on reducing the progression of chronic kidney disease among racial and ethnic minorities. And in our first session, Dr. Sinclair established that declines in renal function appear to be faster among Black and Hispanic people than among other racial groups. And this is true not only among those with early stage compromise, meaning GFR 60 to 90, but also among those with normal renal function test results. And secondly, he gave us an overview of new treatments and guidelines for treating CKD to prevent progression, which could benefit traditionally underserved populations. So today we have asked him to extend his review of these treatment guidelines and provide us with resources for future use and further learning, and also to give a brief overview of what nephrologists want PCPs to have confidence in with regard to testing and screening methods and initiating progression-limiting treatments. So, Dr. Sinclair?
Thank you so much for that kind introduction, Dr. Brock, and that great review. If you can move to the next slide, please. So kind of like Dr. Brock mentioned, I want to really start out by focusing on just basic things about CKD screening that I really want all primary care providers to be aware of. Next slide. So when it comes to lab screening tests that you can do for CKD, it really comes down to two categories, right? So there's blood tests and there's urine tests. And as far as the blood tests go, there's really two main ones I want to focus on. The first one most of you are probably inevitably very familiar with, which is the serum creatinine. And that's because it's quick, it's cheaply run, it's reported on most labs on a BNP or a CMP. And it's very easily plugged into the most common eGFR estimating equation, which include the CKD-EPI equation and the MDRD equation. The second blood test is something called a cystatin C, and while many of you are less likely to be familiar with this test, we'll talk briefly about why it's used and when it's appropriate to order and why it's actually becoming more important. As far as the urine tests go, the only one I really want PCPs to focus on for today and be familiar with is what's called the UACR, the urine albumin to creatinine ratio. And some of you may ask about what about testing for total protein? And well, as a nephrologist, there's definitely cases where I want to have a total protein and a UACR. I really prefer that PCPs focus on UACR as it's been found to be the most strongly correlated with outcomes. And it's required actually to classify CKD according to the KDIGO criteria, which I'll get into in a couple of slides. Next slide, please. Great. So as far as serum creatinine goes, it's why do we use it in the first place, right? So as mentioned before, it's cheap, it's quick. Most providers are pretty familiar and comfortable with it. However, PCPs really should be aware that there are a number of factors aside from GFR that can affect creatinine levels and actually skew our interpretation of it. So these include things like age, gender, nutrition status, hydration status, protein intake, muscle mass, and chronic illness. You'll notice I purposely did not say race as something that affects creatinine. And the reason for this is because race is really an artificial, non-scientific, man-made construct. And unfortunately, the earlier eGFR estimating equations that most of us are familiar with did actually include a race coefficient for correction. Now, there's newer equations that have recently come out in the past year that do not include the race coefficient. And this was due to actually a committee called the ASN-NKF Task Force, which really reviewed this issue and made the decision that it's really not proper to have a race coefficient for a number of reasons. And the biggest reason was the race coefficient was actually leading to delays in care and treatment for African-American patients specifically. And we'll get a little bit more into this a little bit later, but I'm happy to talk about it more during the discussion. But if there's one takeaway from this slide I want you to have from creatinine, it's never the race itself that affects the creatinine, right? There may be other factors that I've listed here, and then some factors that we're still unaware of at this point, but you should never associate race with a difference in creatinine. Next, please. So what about cystatin C? So it's a more expensive test. It costs about $18.50 per test compared to only about $5.10 per test for serum creatinine. It's also sometimes slower to result because not all labs are actually do it, and sometimes it has to be a send out, so that may take a little bit of extra time to come back. And this means that providers are less familiar with it in general and probably less comfortable ordering it, which is why we're talking about it today. And it can be affected by certain things such as gender, height, weight, inflammatory disorders and endocrine disorders, which include things like diabetes and thyroid disease, as well as exogenous glucocorticoid use. However, importantly, it's not affected by things like protein intake or muscle mass, and this is very helpful, especially as a nephrologist. When I have tended to use this test in the past is when sometimes I get a referral for a young, otherwise pretty healthy patient. Oftentimes they're male, they're in their 20s, they may be, somebody who works out or takes a lot of protein supplements, and it's very muscle bound, and they come in with like a creatinine of 1.4, 1.5. In this case, I'm always hesitant that they really have true CKD. So oftentimes I'll use cystatin C in this situation, and we'll find it to be completely normal. And this kind of helps to reinforce that, okay, in this particular patient population, with the patients, again, who have a lot of muscle mass, it's maybe something that's skewing the creatinine upwards. Most importantly, though, and I'm going to get into it a little bit more, is that cystatin C and creatinine, when they're combined, especially in the newer 2021 CKD-EPI equation, it actually provides a more estimation than using either one alone. So there's actually now becoming more of a push to actually get cystatin C on more patients than we were ever considering in the past. Next slide, please. So what does the NKF and ASN task force actually say about cystatin C? So what I alluded to earlier, the NKF and ASN formed a task force in 2020 to discuss what to do with the race coefficient in the EGFR estimating equations. Again, since the current coefficient, which has been around for a long time at this point, was actually disproportionately harming Black patients by delaying their care and delaying them from being listed on the transplant list at an appropriate time. So after a lot of expert feedback and deliberation, they made a decision. Next slide, please. And what they decided was that the new EGFR estimating equation, which again was released last year in 2021, would not have the race coefficient. It was titled the 2021 CKD-EPI equation. Again, it estimates EGFR without the race variable. And the task force also recommended increasing the use of cystatin C and combining it with the serum creatinine as a confirmatory assessment of GFR or kidney function. Next slide. So there are frequently new studies coming out all the time that look at the newer equations and the use of cystatin C. This study actually just came out a couple weeks ago in JAMA, and the consensus is basically the newer equations are better, and that by combining cystatin C and creatinine, that's really the ideal way to estimate EGFR. So again, if PCPs have the ability to order both, it's definitely my recommendation that's something that everyone should consider doing going forward. And I think we're going to start seeing cystatin C ordered by more folks on a more regular basis going forward. Next slide, please. All right, so we've talked a lot about the blood test. So what about UACR? So first, it's an easy and cheap test to order. Next, it's markedly underutilized. So as you may be aware, patients with diabetes or pre-existing albuminuria are supposed to have a UACR done annually. However, a recent study noted that among patients with diabetes, hypertension, or both, it's actually done only about 21%, or among 21% of people. And then finally, as you'll see on the next slide, this test is critically important for both prognostication in addition to helping to guide treatment decisions. Next slide. So as far as prognostication, this heat map I love. It came out in 2012, but it's still something that we as nephrologists use very frequently. And anytime I introduce it to someone new, they love it as well, because it really kind of breaks down why both the blood and the urine tests are so crucial. So this was from what's called KDIGO, which stands for the Kidney Disease Improving Global Outcomes. And it basically shows the different EGFR categories, which you can see go from G1 to G5, and then G3 is broken down into A and B. And then you have the albuminuria categories, which are categorized as A1, which would be considered normal, A2, which would be 30 to 300 milligrams per gram of creatinine, that's considered microalbuminuria, and then greater than 300 milligrams per gram of creatinine, which is considered macroalbuminuria. Then within each EGFR stage of CKD, you can see that increasing proteinuria is associated with an increased risk of progression. So the green boxes are the best and the red boxes are the worst, and anything in between. You can see there's a yellow and orange in between, which are kind of in the middle. So you can see, for instance, if you're stage G1 or G2, but you have no albuminuria or minimum albuminuria, you're green, so that your risk of progression is fairly low. However, if you are in those same categories, but you have macroalbuminuria, you suddenly jump to orange, which means that your risk increases pretty dramatically. And then same thing if you look at G3A, which probably the majority of patients that we see as nephrologists kind of get referred to us either G3A or G3B. Again, if you have, microalbuminuria, no albuminuria or normal albuminuria, your risk of progression is in the yellow category, which is not zero, but it's a lot smaller than, let's say, for instance, you have uncontrolled or macroalbuminuria, and again, you kind of move to the red category, which is why it's so important to not just have the blood test, but also the urine test when it comes to prognosticating and then also guiding treatment, which we'll get to in the slides to come. So next slide, please. All right, so let's move on to treatments. Next slide. So in my limited time talking today, I regrettably can't give you a complete crash course in being a nephrologist and the treatment guidelines that I'd like for all of you to know, but I would like to focus on two really key areas of CKD management that I want all PCPs to be aware of when it comes to slowing the progression of CKD. And the first goal should always be treating the underlying cause. So in this country, diabetes and hypertension are the two most common causes of CKD and the development of subsequent ESRD. And then other things to be aware of are obesity, heart failure, some genetic causes, and then there's a potpourri of other things such as infectious and autoimmune and glomerulonephritis that may cause CKD management. So always, if you could treat the underlying cause, that should be the first step. Next, please. And then the next thing, aside from treating the underlying cause, is to limit albuminuria. And again, based on what I showed on the last slide, you can see why limiting albuminuria is so crucial when it comes to limiting progression. Now, I'm sure most of you are pretty familiar with RAS inhibition at this point, ACE inhibitors and ARBs, which have been around for a while. But there are some newer therapies that can also limit albuminuria, really, that have come out in the past 5 to 10 years. It's pretty exciting, definitely in the nephrology world and the endocrine world and even the cardiology world. And I want to definitely make sure the PCPs are as excited as I am about it. So next slide, please. So you can see, again, over the past 5 to 10 years, there's really these two, more than two, but these are the two main classes of medications that have been tested in what's called, they did cardiovascular outcome trials where they actually look not only on the glucose lowering effect of these medications, but also look to see cardiovascular outcome and assess for safety. And it actually, these studies were fantastic. They showed not only do these medications, the SGLT2 inhibitors and the GLP-1 receptor agonists, lower glucose, but they also have a number of other incredible effects, as you can see on the slide. So they do things like, and then, again, there's a lot of overlap. So they both reduce albuminuria, they slow the decrease of eGFR. We mentioned they lower plasma glucose. They also lower blood pressure. They've been found to increase weight loss. Specifically, the GLP-1 RAs are indicated actually for weight loss. They both have significant cardiovascular benefit, which included a reduction in negative cardiovascular outcomes like MIs and ACS and other such things. And then you can see that the main difference, while there's a lot of similarities, is that while they're both approved for use in diabetics, the SGLT2 inhibitors are actually also approved in non-diabetics with CKD, based on a trial that came out a couple of years ago. Whereas the GLP-1 receptor agonists are approved for non-diabetics with obesity. And a lot of my endocrinology colleagues will actually use it for this purpose. But from a kidney standpoint, these are both actually fantastic medications and have a ton of benefit, as you can see. Next slide, please. So I love this algorithm. This is from the ADA, the American Diabetes Association, came out in 2020. And while this just goes through the algorithm for diabetes, as I mentioned, diabetes is the #1 risk factor for the development of ESRD in this country. So it's really relevant to know how, again, how to treat diabetes and specifically type 2 diabetes and what steps should come after metformin. So you can see on the top, the first line therapy is still metformin and lifestyle modification. But then once you get to kind of having any other comorbidity or uncontrolled hyperglycemia, the next step is really adding one of these medications that I mentioned. So you can see for whether the patient has heart failure or CKD or ASCVD, high ASCVD risk score, or weight or needs to lose weight, you can consider an SGLT2 or a GLP-1 for either of these, for any of these conditions as the next step. And you can see that if one of those medications isn't enough, you could actually then go ahead and add the second one on. The only issue, and you can see on the right side of this algorithm, is cost is a problem. And that's something that I'm very interested in my research. And it's something that, you as PCP should definitely be aware of, and hopefully something that social work and case management can help with. It's not there's no perfect solution. These medications are awfully expensive without insurance. The SGLT2s could be up to about $500 or $600 a month without insurance. And as we know, a lot of our underserved patients, unfortunately, are either underinsured or uninsured. Luckily, I think Medicare and Medicaid are starting to cover these meds if they don't already, at least usually one per class. And they're really class effects. So I wouldn't worry so much about which particular medication is just making sure that the patient is on at least one medication from the class if they meet indications. Because again, the studies that have been done have tested, there's been tests on various medications from the classes, and all the medications seem to have benefit. So as opposed to being just a singular medication effect, it's really a class effect. And as far as the number of medications per class, it's about 3 or 4 medications per each of these classes. There's a number of choices. Next slide, please. All right, and I think this is my last slide. So while we just scratched the surface here, and I definitely want to talk more about this in the discussion, I have 3 main takeaways. Next point. So first, just be familiar and comfortable with ordering a serum creatinine, a cystatin C, and a UACR, and be able to interpret the results. Next. Second, being able to use the eGFR and the UACR results to help guide treatment. And then next. And then finally, being able to treat the underlying cause of CKD as well as the albuminuria. and then considering an SGLT2 or a GLP-1 receptor agonist as an add-on in diabetics, and then in an SGLT2 inhibitor specifically in non-diabetics with CKD. And I think that's my last slide. So thank you everyone for your time, and really looking forward to talking more in the discussion.
Thank you, Dr. Sinclair. That was a lot. Thank you for boiling down for us some sort of consolidated resources. So next slide. So next is Dr. Maureen Bezold, and she's an associate professor of public health in the Department of Health Sciences and Social Work at Western Illinois University. Dr. Bezold has served on the American Public Health Association's Governing Council and as a program planner for the Emergency Preparedness and Response section of the Illinois Public Health Association. Her current research interests include emergency preparedness and access to services for medically underserved rural communities and for the disability community. She is also the recipient of a kidney transplant. In our first session, she reflected on her experience and research to describe the importance of patient self-advocacy and gave us an overview of some of the challenges in accessing renal replacement therapy in rural communities, which often have poor access to resources, including information, available transportation, and support for housing and other costs associated with out-of-town care requirements. So today she's going to extend her comments by presenting some of her research around the determinants of access to renal transplantation. So Dr. Bezold.
Camera, huh? And unmute. Can you hear me now?
Yes.
Okay, great. So, thanks everybody for inviting me to be part of this. I am really pleased to essentially represent public health side of things, but also to represent all of us that have gone through chronic kidney disease all the way to the point of transplantation and the afterlife, so to speak, of being a kidney recipient. So this research that I'm going to present to you today is actually from a study that was spearheaded by one of my former students. So two of my students were researchers on this, and I, of course, was invited to be part of it because turns out I was the one that inspired them to even think about it, which was really quite touching, frankly. So what they looked at is trends in chronic kidney disease and determinants of access to renal transplantation. And it is a retrospective analysis. So we cover 2002 to 2016. So next slide, please. So here's the introduction of our study. First of all, the rates of chronic disease, chronic kidney disease and end-stage renal disease continue to increase in the US, and that was particularly so for that time period. And then not only that, from 2002 to 2016, the US experienced a greater disease burden due to chronic kidney disease than any other non-communicable disease. And we often think of heart disease and cancers and so on as being the number one diseases for disease burden in the US. But it turns out for that time frame, it was chronic kidney disease. Additionally, individuals 20 to 55 years of age, so again, the younger folks that Dr. Sinclair alluded to, they experienced the highest increase in mortality due to chronic kidney disease. And I think, and this is my supposition, so don't quote me on this, but my guess is it's because we don't think of people that age necessarily being susceptible to having chronic kidney disease. Next slide, please. So the purpose of our study then was to determine trends in renal transplantation following chronic kidney disease, and then the factors that affect access to renal transplantation. And I'm sure some of you can guess. And this is of particular interest in the county that I currently live in, McDonough County, Illinois, which is about 3 hours directly north of St. Louis, Missouri. We have a nearly 25% poverty rate in our county. And we are in the middle of absolutely nowhere, Illinois. And so we are medically underserved in our area. So you get an idea. I was diagnosed in 2017, June of 2017. And after I began dialysis, we opened, or someone, you're represented here, one of the kidney dialysis organizations opened a location here, but that is only for people that can come and stay to have their dialysis done at the clinic. And so that was the closest access for anyone here, but that only arrived after 2017. Next slide, please. Okay, so the methodology for our study, we used data from the National Inpatient Sample, studies from 2002 to 2017, using the internal classification of diseases. And this means more to my medical people than to many of us. So they studied this particular cohort that they found fell into this chronic kidney disease and renal transplantation. Secondary data using multivariate regression was employed to determine predictors, and the samples were weighted to generate national estimates. Next slide, please. So the results show that there were 9.25 million hospitalizations associated with CKD in this data set from 2002 to 2017. Less than half of 1% received renal transplantation during that study period. Okay, and again, less than half of 1% received renal transplantation during that study period. On average, about 5% of the people who need transplants actually get them in any given year. So realize that renal transplantation is very rare given the number of people that need it. So the trends in CKD increased from 2,562 per 100,000 to 12,649 per 100,000 hospitalizations from 2005 to 2017. That's a six-fold increase. That's pretty astounding for a 12-year period, fundamentally. Trends in renal transplantation have stabilized to, again, less than 0.5% during that period. So next slide, please. Black patients and patients with public insurance had the highest level, highest prevalence of CKD. So again, Black patients and people with public insurance, so those that can't afford their own, can't get it from an employer, had the highest prevalence of CKD. Hispanics and patients with private insurance were more likely to have renal transplantation following CKD. Okay, so not nearly as likely for a Black patient or someone on public insurance to have transplantation. Higher access to renal transplantation, males have higher access, older people have higher access, those with a higher increase in median income have greater access, and people with private insurance have greater access. So I guess I fall into the older folks category, not the male. My median income is increasing. I'm very blessed to have a job I love and am able to increase my income based on my activities as a professor. And private insurance through the university offered by the state of Illinois. And I must say, there are some lovely benefits to having that insurance if you've put in your years at the university. Next slide, please. So conclusions. The prevalence of CKD and end-stage renal disease has continued to increase in the US. Higher socioeconomic status remains a major driver to access to renal transplantation among people with CKD. So that's the conclusion of the research. And I believe there is one more slide here, right? And this is based on my own personal experience now. I live about 2 hours from where I was getting care for my kidney disease. It was 2 hours away. I am lucky enough to have a very flexible schedule. I can say at the drop of a hat, hey guys, we're going to have class via Zoom tonight rather than me being there face to face, or what have you. So I am very blessed to have the flexible schedule I have. So I can drive the 2 hours there, spend the half hour sometimes there, and drive back. But at some point, some of my care required overnight stays. So when I was learning to do peritoneal dialysis, which is what I did, I had to stay literally for 4 nights to go through my training and pass, so to speak. We had training for 5 days in a row. And I was very lucky. The nurse that I worked with at the dialysis clinic decided to come in on New Year's Day and help me with my first day of training. The clinic was closed, but she did it anyway. So I was very blessed in that regard, but I had to spend 4 nights in Springfield, which is where I went for care, because I lived 2 hours away. And for anybody that's ever had chronic kidney disease or knows someone who has chronic kidney disease, you are exhausted all of the time. It would not have been safe for me to drive home after having my treatments, to tell you the truth. Some of the other challenges people face because they're taking away family resources. It costs money to stay overnight when you don't have a foundation supporting it, or if you don't have whatever it might be that you need. Medications are extremely expensive. Some people don't have the wherewithal to afford those. One medication I was taking, it was an experimental medication prior to having to go on dialysis, cost $13,000 a month. I was very lucky that because I was part of a study, I did not have to pay for those meds. Medicare coverage doesn't start until you start dialysis. And so there are a lot of expenses that people can't pay until they get sick enough that Medicare kicks in. That's not the way it should be. It should be so that you don't get so sick. You should have help paying your bills so that Medicare can save money. And for those of you who don't know, it costs approximately $100,000 a month to be on dialysis. One of the positives, here I state, is that Medicare does kick in. Any costs that you have are absolutely minimized. I don't think I saw a single bill after my Medicare kicked in for dialysis or for transplantation or any of the care post-transplant. So that's all I have to say for now. I am open to any questions. I just want to say a shout out to one of the people who represents, who provided my dialysis care, and also to the people from Wisconsin for joining. I'm a born and raised Wisconsinite, and I just really appreciate knowing that people in Wisconsin are worried about this issue too. Thank you.
Thank you, Dr. Bezel. That was really very compelling. So next slide. So Deborah Johnson is the Community Engagement and Health Planning Manager with District 5 in the Oklahoma State Department of Health. She holds a Master's of Science in Behavioral Health and is a candidate for Doctor of Public Health, where her focus is on psychoneuroimmunology. I said it without stumbling. She is one of 30 trainers in the state of Oklahoma with expertise in the biological impact of life experiences, including adverse childhood events, on nervous system function. She currently leads the Lawton Fort Sill Self-Healing Community Coalition and conducts trauma-informed community conversations. In our first session, she taught us a lot about the impact of social and other stressors on health generally and CKD specifically, and the opportunity for community health and social supports to mitigate these stressors. So today she's going to expand on that. She's going to briefly review the link between stress and health and the link between socioeconomic disadvantage and CKD outcomes, and distill some practical advice for community organizations and individuals to promote community health locally based on her experiences and work in Oklahoma. So, Dr. Johnson?
Thank you, Dr. Brock. It's such an honor to be on the panel with these experts and to be back and talking a little bit more about this topic. Specific for me to public health related to those health disparities, social determinants of health. We know there are populations who experience significant disparities when we're talking about chronic disease. And when we relate that to chronic kidney disease, there are significant barriers really at every step. If we'll go to the first slide, please. So we know that, within our environment, there are psychosocial factors, there are behavioral factors, and these are leading to risk factors then that are increasing that risk for chronic disease. Oftentimes we talk about probably more so the behavioral factors, smoking, drug use, alcohol use, and those leading to chronic disease based on the behaviors. But what I study and enjoy talking about is really what's happening inside the body as a result of increased hormone release. The stress that is happening around us is also happening within us, and that's leading to a higher risk of chronic disease. And we know that depending on populations, access to care, just environmental stressors, that the stress you're feeling and experiencing is higher with certain populations as well. Next slide, please. So when we look at the common risk factors for CKD, we see, again, smoking, we see diabetes, heart disease, blood pressure, age can be a risk factor, obesity, and family history. A lot of these are similar when we look along with any chronic disease. We see these risk factors, and in Oklahoma, and in the states that are represented here as well, these are the key areas we look at when we're talking about prevention. When in public health, we're trying to educate on really focusing on addressing things more upstream and not waiting, as our last two speakers have talked about, where we're experiencing barriers that are other factors, the environmental aspects, as well as the deprivation that's occurring. So next slide, please. Something that we want to bring to the conversation, though, is just what's happening when we look at, psychonephrology related to CKD. So on the brain image scan here, you can see activation of different areas. And we know in response to stress and anxiety and depression in our environment, that the scan is going to reveal the activation, the areas of activation in the brain. And, the brain stem is much more reactive in those times of stress and when we're responding for survival, frankly, versus where we want to be operating ideally is that frontal lobe, where we're problem solving and being able to think ahead and plan. And so when we're in this environment where we're reactive, we're experiencing significant barriers through economic deprivation, through our psychosocial environment, that is in our brain releasing this signal to the HPA axis, which is where the signaling to our adrenal gland is that activation, increased activation of hormone level. And so you can see on the slide that it's not just our liver, but it's our other organs as well that are then being impacted by this increased hormone level, leading to inflammation. If you look at neuroimmunology and decreased immune response, but also just this increased risk with our kidneys for kidney disease. Next slide, please. So I think I might have referenced this slide in part one of the panel, but again, just breaking down, some of the details and the barriers related to what we see with CKD in particular populations. The high risk, it was mentioned, of those who are uninsured. When you're looking at access to care, whether it's whatever stage of CKD the patient may be in, we know that you're going to have the hub within your state are those larger populous centers, and so for those of the population outside of that, and Oklahoma as a rural area, and our other states on as well, that's where you see the distance and the barriers to the care very clearly. But we also see just that kind of environmental change that we've all gone through as a society, navigating differently in relationships, in our neighborhoods, the ability to connect with people. And we've certainly seen isolation and things increase through COVID, how that impacts populations. And so considering these building upon factors that were already present in some communities who lack the access. Next slide, please. So when we look at access and coverage and the cost, with all things public health, we know it's that public health network that really is going to have to come together and collaborate on the individual level. If we're looking at screening tools, we talk about, we know one aspect of this is the stress that's present in the home environment or in the life of that individual. So the perceived stress scale, introducing that with clients, or looking at a needs assessment tool. CSM or CMS has the health-related social needs screening tool, or the Prepare tool, which is from the Association for Community Health Centers. Looking at the whole person and considering these other factors, connecting them. And so health in all policies, going back to CDC and revisiting at the community level. And then, in Oklahoma today, we're voting as well. And so looking beyond local, state level as well, that health is considered in all of our policies, and that we are collaborating toward that goal of access and reducing the health disparities. Thank you.
Thank you so much, Dr. Johnson. This is all so very fascinating. I have a bunch of questions for you, but I think that we can probably wait till the end. Moving on, our last panelist is Dr. Ronald Wyatt. And Dr. Wyatt is Vice President and Patient Safety Officer for MCIC Vermont, which is a major risk retention group based in Burlington, Vermont. He's co-chair of the American Board of Internal Medicine's Equity Action Group, which is an outgrowth of the ABIM Trust Initiative, and is also a Senior Institute of Healthcare Improvement Fellow. Dr. Wyatt was the first patient safety officer at the Joint Commission, is a board-certified internist with over 20 years of practice experience, and is a facilitator for the AAC-GME Equity Matters Collaborative. In our first session, he reviewed the extensive role of racism in CKD outcomes, including the historical CKD and heart failure algorithms that Dr. Sinclair has already discussed. He reviewed the social determinants of kidney disease, including people working in underappreciated jobs and having much reduced access to health support and medical care. And even when access to care is technically present, there's disproportionate exposure to poor quality care, as demonstrated in part by much higher risks among people of color for acute kidney injury during surgical care and post-operative sepsis. So today he will focus on building trust in the care system, especially among Black and Brown populations, and how to help build health equity commitments from within institutions. Dr. Wyatt?
Thank you, Dr. Brock, and thank you to all of you for being here with us today. And also thank you to the wonderful presentations by the three previous presenters who frankly all, in addition to just being excellent, triggered me a bit. And I'll tell you what I mean. So if we go to the next slide, I'm going to talk about trust. And I'll start with a bit of a story that was triggered by all three of the previous presenters. I'm over 60. I have essential hypertension. went to see an internist that is a little over an hour away from me. First time I ever visited with him, and I'll be explicit, a middle-aged white male internist. And during that first visit, he listened to my lungs and heart through 2 layers of clothes. He asked me when was my eye exam, but never looked at my retinal vessels. He asked me, did my legs ever swell, but never looked at my legs. And then when he finished, he said, we'll keep you on the same medicines and we'll send you to the lab. And I said, oh, good, because I drove over an hour and I really need to urinate. And he just nonchalantly said, oh, I don't need that. And I was puzzled at that. So when I finally got my lab results, being on the medicines I'm on, I expected that I would get a measure of my renal function and my electrolytes. A panel was not even run. And a urinalysis was not done. I received a lipid panel and a CBC. And interestingly enough, I received a hemoglobin A1C, and I have no history or symptoms of type 2 diabetes. Well, when I finally tracked down the results, I contacted the office because the message said that he wanted to start me on a statin. And based on the algorithm, I'm not a candidate for a statin. And in addition, no liver enzymes were checked. And particularly, if he were contemplating starting me on the statin, I would have expected some conversation about a CPK, or at least some other conversation about my atherosclerotic cardiovascular disease risk and the things that I should be doing. None of that took place. So that led me to say, and to say to you, I do not trust him and I will never go back. So that is the place we're at in terms of trust. It is a crisis and it is an epidemic. Can I go to the next slide? So then if we think about that, we need to know what we're talking about. We're going to talk about, as the initial objective showed, the root causes and some actions to build and rebuild trust. Next slide. So this is what's called the trust triangle. And the reference is there, but let's start with the trust triangle and what are the necessary components of a trust triangle. First is empathy. Feel me, see me, listen to me. Next, logic. We go in to see subject matter experts. In a trust triangle, the expectation is that the experts will exercise fair judgment. They will exercise fair input with me in order that we form a partnership that's essential for any of us to manage our disease processes. Next is authenticity. Are you being real with me or are you not? If I look around and see that your team is not diverse, I will question, are you being real with me? And do you care about me? So that's where the diversity, equity, inclusion comes in. When a person is authentic, the organization, the system, the team should reflect that authenticity. Next slide. So these are the questions that go along with this. For empathy, do you care about me or do you care more about yourself? Logic. Next slide. Then how sound is your reasoning? And if you don't trust your own judgment, then why should I trust it? And then again, authenticity is show me the real you and I'll follow. Next slide. So this is, again, a brief story that's published, and I asked Dr. Brock to mention the work of the American Board of Internal Medicine Foundation, where I'm co-chairing an equity initiative that grew out of a Building Trust initiative. I will say that 2 of the most highly positioned people in CMS, in the Office of Clinical Standards and Quality, are members in this group as we began to think about how do we build and rebuild trust. And you can go to the ABIM Foundation website and see some of the work that we're doing with some of the leading organizations, leading leaders, businesses across the country. And this, another brief story that came out of building trust was when my grandson, who's now 2, was taken to a pediatrician a little less than a year ago because his mother, who was a registered nurse, noticed that he didn't breastfeed well and he wasn't holding food in his mouth when they tried to feed him. My son called me from the pediatrician's office and said, "Dad, I need to ask you a question because I'm confused." I said, "Okay." He said, "The pediatrician told us that my son has a lip tie." And he told us that, and I'll say again, another younger white male physician, he told us the best thing you can do for him is just let him run and walk until he falls. And when he falls, that should tear the lip tie loose and he'll be fine. And he said, "Dad, I don't trust that." That word comes up again. "Dad, I don't trust that." And my son has no medical background. By now, he said that my grandson's mother was in tears. They took the child to a dentist and did a frenectomy and solved the problem. Next slide. So trust is essential. And we're talking about the frame of chronic kidney disease. For us to practice assiduously, evidence-based best practice for all people, trust is essential to that practice. Next slide. Because we have to grow that trust. We have to look at where it came from. And when we think about the history, we can no longer be ahistoric about where trust began to fail. I'll go back to me again. When I went to see that internist, I have the Cigna Health Insurance Platinum card. It wasn't a matter of lack of insurance, a high education level. It wasn't a matter of my educational income. Something else is operating. And it began way back before the 1800s in slavery, when the idea for not just Black and brown people, but all people was for a physician, be obedient. I will tell you what to do, how to do it. You have no voice in it. You just obey and do what I ask you to do. That evolved to the 1900s, when it became more around a more personal trust and saying, how do we build trust in a relationship? Bringing that personal care to the encounters that we have with people. Well, that's given away to now. And all of the evidence that was just presented to you by all of us will say to you, no, I will not trust you because you just tell me to. Show me that you care about me. Show me that you listen to me. Show me that you respect me. And then we can build trust together. Next slide. So that's just been historic decay of trust that we now call the trust decay, that's highlighted by what you see here. It's hard for us to separate facts from other data that's coming at us every day, particularly now, even as we speak. In social media, when we see what's the truth and what's not, where does the line begin to blur between personal opinion and fact? That's becoming increasingly difficult. We are bombarded through social media and other sources of what's been labeled fake news. The result is what? Declining trust in the sources that we previously, like healthcare, previously we relied on for factual information. Well, now, because of this lack of trust, people increasingly don't trust the government, don't trust the print media, don't trust books or the judicial system or even the presidency of the United States. Next slide. So then when we think about just quantifiably what has happened in this trust decay, when people are asked about trust and the question is top box, do you trust quite a lot or a great deal? Do you have a great deal of confidence in the US healthcare system? From 1966 to now, it's dropped from 73% to 44%. For people of color, as Dr. Brock mentioned, if you're under 50 with lower levels of education, lower incomes, you have lower levels of trust, and we'll show you some data. And then where do we rank as a nation? 21st in citizen trust of the healthcare system, 21st in the world. Very low if we put our healthcare system in with other industrialized nations. Next slide. So something was mentioned earlier in the presentation, trust and discrimination. Did I feel discriminated against when I went in to my internal medicine visit? I absolutely did. Well, the facts support me. Black respondents to this question are twice as likely to have experienced discrimination in a healthcare facility. And those who were discriminated against are twice as likely, just as I am, to say, I do not trust the system. Next slide. And when we look at trust and discrimination by race and ethnicity, and here are the numbers, and whether we were Black or Hispanic or white, these levels of trust are pathetic across the board. Believe physicians trust what patients say. As best we can get is 80%. The physician spends enough time with us. 80% is the top. Physician cares. Doesn't even reach 80% for all groups. For all groups. Next slide. So do you trust your primary care physician? I went into my primary care physician, and that's why I mentioned by age or race or income, the numbers are right in front of us. If I go to my age group, as we grow older, their trust in the primary care physician should increase. When we look at race, though, look what happens. There's a drop off. When we look at income level, as was mentioned earlier, trust increases as your income increases. We need to better understand these numbers and what they mean. Next slide. Well, let's ask about physicians then. Physicians. A third of the physicians don't trust their own healthcare organization leadership. And even fewer trust the executives in general. That's what these numbers say. Well, I'll make it real again. When I was about to leave organization I practiced in for over 15 years, making that decision, a big surgical specialty group had just left the organization. The CEO said to me, the reason they left because they don't trust me. Ron, I want all of, quote unquote, my people to be happy. Ron, do you trust me? And I will say to any of us, when you ask that question, you got to be prepared for the truth. My truth to him was, no, I do not trust you. And I'm not your people. You don't own my happiness, nor do you own me. Trust has to be earned. Next slide. And that's from physician's perspective. So then what are the barriers then when we think about trust? And here's just a listing. You can have this, you'll have the slides and go through the numbers. When we talk about, did I fill my prescription? That you follow the treatment orders? Did you follow up on your appointment? Did you make the lifestyle changes? And if you look by race and ethnicity, look at those numbers. So we have to begin to ask from my patient safety perspective is why? Why is this? When I talked to my young barber when I was in Chicago, about 27, 28 years old, I asked him, what's the thing that's going to help you take care of yourself when you see your primary care physician? He said 2 words, respect is number 1. Respect is number 1. The next one, in his words, what he was saying to me was a physician who shows me empathy. Those things matter. And we're easy to label people non-adherent or non-compliant when the fact is they don't trust us. Then we turn around and say, well, it's their fault, not mine. Next slide. So there's a trust crisis here in Alabama. Here in Alabama today. If you treat a transgender person, you risk facing legal action. 8 years ago, I saw a story here in Alabama where it said a mother took her child who was questioning to 23 pediatricians here in the state of Alabama. The physician that took that child, name was in the paper. I called her because we knew each other when I was on faculty at the University of Alabama, Birmingham. I said, tell me this is not true. She said, no, it's true. A mother took a child to 23 physicians, transgender and white. And then we say, trust me. Next slide. So why then? What's driving this? First and foremost, we don't spend enough time talking to people, and we don't spend enough time listening. But when we apply to medical school and we're asked that question, and I sat on the admissions committee at the University of Alabama Birmingham School of Medicine, and I answered it the same way. Why do you want to go to medical school? Because I care about people. Because I want to help people. 25% say you don't spend enough time with me. And you don't listen. Next slide. So imagine a more complex patient then. like a person with chronic kidney disease. Well, what about physicians then? A third say it's gotten worse since COVID. Trust levels have gotten worse since COVID. We're faced with burnout. We're faced with making decisions in a rapid fashion. And when we feel that kind of pressure, production pressure, we make quicker decisions. We don't listen enough. And what happens then is people are impacted by the system that put us in that position, the environment in the first place. And I experienced that in my visit when I went over to see the internist, when the young physician's assistant spent a lot of time with me, listening to me, hearing my story. And then she said, oh, I got to hurry up and finish now, because if I don't finish before he comes in the room, I'm going to be in trouble. And I'm sitting there thinking, what kind of system would put that young medical assistant and that internist in that kind of environment, that they feel that kind of pressure when you're seeing a person? Reflect on that. Next slide. Physicians believe that spending time is important to building trust, but a quarter of them say they don't spend enough time. Again, it's the system and the environment that we're put in. And it's reflected in outcomes. It's reflected, I go back to logic, it's reflected in judgments and clinical decisions that lead to worse than expected outcomes. Then we scratch our heads and say, we don't understand, we need more research, we're not sure what's happening. Yes, we do. It's time to confront it. Next slide. 3 things that influence your levels of trust in the healthcare system. Is the care quality care? Is that caregiver there when you need that caregiver to be there? And back to my young barber, was I treated with respect? I will tell you absolutely from my visit, I was not treated with respect. Then you see the other things here. And again, you can go through those slides. Next slide. So something mentioned earlier, and I'll revisit it. When we think about equitable outcomes, we have to get to the root causes of distrust, mistrust, and no trust. And those things were mentioned on the sidebar. You saw those in the previous presentation. But we have to think about this in terms of what can we do now? And then how can we change as an individual and as a group? And then how can we change as a system? So to do that, then we've got to get to the root causes. We got to get down deep to the root causes that are going to be challenging and difficult to uproot. These root causes cause bitterness, they cause distrust, they cause mistrust. We have to think about, how does racism operate in my system? Does it operate on any one of these levels or all of those levels? And again, we cannot be ahistorical about racism. It is a root cause of what we see throughout the system, what we call social determinants, that we now call social drivers of health, and that's where CMS is, even as we speak. Because the CMS social drivers to measure inequity are in rulemaking at CMS, and now we're confronted with these things will likely be conditions of participation and US code, that means law. Because we have failed to respond. Short-term, medium-term, or long-term. Next slide. So then, as we think about it, how do we begin to rebuild a system of trust? Humility. Structural humility and competence. What does that mean? That means when a person comes in to see us, they bring their political, their social, their economic self with them. For Black and brown people, for people who have disabilities, cognitive or physical, for people that have sexual orientation, gender identities that we're not comfortable with, for people that live in isolated rural areas, and the elderly, white and poor. We all bring our historic trauma with us. Structural humility and competence says we better understand that as a competency to build trust. Listen with humility. Listen. And then ask to be invited into a person's life. That's shared decision-making, which lacked in my visit. understand how we can build a system of shared decision-making that partners with organizations, people, communities. And then how do we begin to dismantle structural and institutional racism? First, admit that it exists, begin to understand how it operates, and then act on it. Next slide. I'm almost done. So when we rebuild trust at the individual level, understand that for me and my experience, it's going to take time. We need to look back to authenticity, look for real apology and reconciliation. Do I see dependability and predictability? What does that mean? A person's future behaviors largely rest on what they intended. What are your intentions? And are you making it visible? And then right here and right now, people are in front of us. I'm sitting here in front of you. Focus on me right here, right now. And then as an individual level, I include myself. At some point, we have to take a leap of faith and say, yeah, with optimism and hope, we're gonna get better. We're gonna rebuild trust. I have to believe that. Next slide. So then it becomes to think about, even before you begin the rebuilding process, how will it be sustained? We have to, again, have the intent, make conscious efforts to trust, be trustworthy, be transparent and honest with people that we serve and with our teams. What did I get right? What did I get wrong? What did I learn from that? I made a misstep. I need to make sure that I don't make that same misstep next time this person comes in. What are the standards that we establish? And that's, again, what CMS is doing now. What are those standards around trust? And that's what the ABIM Foundation is doing. What is it going to look like, including all the way down to research? And then have values. Define what our values are and make them visible. Act on them. Say, this is who we are. Next slide. So this is going to be a challenge for many of us. But I'm saying, and for many organizations, I say this, think about how as a system and institutional organization, you commit to saying we are going to be an anti-racist, multicultural, transformative institution, organization, QIO, whatever your initials are. That means going from being a segregated, exclusive club to being an inclusive, transformative institution. That means going from looking at racial and cultural differences, sexual orientation, gender identity differences, I'll put in here as intersectionality, going from seeing these things as deficits to seeing them as assets. That's going to make the entire system more resilient, more sustainable, and stronger. That means going from a multicultural organization to being, again, anti-racist and multicultural. Next slide. So as I finish then, what I often hear, and I've shared maybe with you before, is people say, well, you know, this is going to be really hard. This is going to be really hard work. And I borrow from the youngest poet laureate of the country when she said, but we're learning. Are we ready? No, we're not ready. But we're being ready. These experiences, what I'm sharing with you today, what you've heard, this is readying all of us as we all continue to learn how to do the hard work. Next slide. But truly, if I go back, I'm sorry. So there's a piece missing, but the visual's missing, but I'll say to you, it's not hard work, it's hard work. Hard work requires apology and reconciliation and healing and restoration. That's part of the learning. We all need to learn how to restore, how to apologize, how to be genuine, how to show our heart in a humble way to say, I'm called to be a servant. The people with chronic kidney disease are not there to serve us. We are here to serve them. What's so hard about saying that? If we say how hard this is, if you say, I'm here to serve you, help me. And just like the previous speaker, well, maybe I didn't know you had to drive 2 hours to get here, right? I didn't know that you had to leave in a rush after I kept you waiting because I had to go to the school to get my kids to get home because I can't afford the cost of aftercare if I'm not there on time. And if I don't show up, don't assume that I'm just being non-adherent. Understand my life and my world, and I'm asking you to be a part of it with me. And then we can be ready together. That's my hope. That's my optimism. And I think collectively, we will get there. And I will say to you, it's hard work. Keep the faith. Thank you.
Thank you, Dr. Wyatt. Wow. Thank you for such an impassioned presentation of all of that information. And I would say that to all of the panelists as well. I think, Lynn, I think I'd like to go to you for questions in chat. I know I saw one come through about, training. Go ahead.
Mm-hmm. And actually there were two questions and they're kind of related, so I'll read them both out. They came up during Dr. Sinclair's presentation, but I think they sort of extend a little bit into the concepts of other presentations as well. So one question is, could you share language or a statement that would help patients advocate for both of the screening tests, the EGFR and the UCR? And then the second question that came in is sort of an agreement, yes. What can patients do to advocate and or ensure that their providers are doing all the right tests and looking at all the right things to diagnose properly? So those are the two questions that we got in chat.
Yeah, so this is for the panelists. Are all of you working with materials or training, or do you have tools and resources where we either could promote patient self-advocacy training, or people could learn on their own how to advocate in the presence of, you know, an authority figure, which is often the clinician and sometimes the larger and more intimidating clinical team?
Yeah, I could start. I mean, it's a great question. I think the first step was just attending this discussion. So thank you for being here and just knowing this information, because I think, you know, a lot of the information that I gave and a lot of the information some of the other panelists gave, just probably, I won't say the majority, but a good number of PCPs may not even be aware of some of that information. A lot of this information is new, especially with some of the newer screening guidelines that I mentioned. So I would say, and kind of to Dr. Wyatt's point, you know, if you have diabetes or you have hypertension or you have CKD and you're going to your doctor, and you could just ask them, first of all, like, so what tests are you checking? If they're not getting a urine test, you could say, can you tell me why you're not getting a urine test? You know, and just being aware, again, some of these guidelines, you know, the guidelines could be fairly complex, but at least say, you know, I know from just speaking previously with other experts and nephrologists and other physicians that I should at least be getting a urine test and my kidney function check once a year by a blood test. So if you're not going to do that, can you explain to me, you know, what your thought process is behind it? So I think just confronting them in a, you know, in a kind way, but just making it aware. I mean, again, some people may just, you know, may not be thinking of that as the first thing in their mind for whatever reason. Dr. Wyatt's doctor decided to not check a urine test and didn't even check a BNP, which, you know, as a nephrologist is pretty concerning. But you know, just make them aware. I would say, I don't want to say necessarily give them the benefit of the doubt, but, you know, approach in a way where you just want to get the information and you're kind of giving them the opportunity to explain it to you. And if they have, you know, I can't think of a good reason why they wouldn't want to check these tests, but if they have a reason, then, you know, counter them with, okay, well, you know, I'm aware that these are the recommendations, recommend getting them, you know, once a year. Would you mind going ahead, even if you weren't going to originally do it, go ahead and just put in a urine test, you know, check my urine albumin or at least check my creatinine, if nothing less. The cystatin, I'd love to get there, but I think it's going to take us some time to get there. But at least a creatinine and a UACR, I don't think they're both cheap tests. They're both tests that every PCP knows how to order. So I think just bringing it up in the first place, and just showing that you have the knowledge as a patient, you know, that's going to go beyond what probably 90% of patients know, just even having that kind of baseline knowledge that we talked about today.
Yeah, I'll just add quickly that in one of the slides, we just didn't have enough time, but however you begin to plan and structure a shared decision-making process. Part of that could be a patient family advisory council. But if you have something in your shared decision-making process, it doesn't have to be some state-of-the-art entity, but it's how you partner with people around these decisions and what needs to be done based on evidence, particularly for this population. So shared decision-making, learn about it. How can it be applied where you are? I'm working with 4 different big equity collaboratives again, from Boston to Chicago to Kansas City to Seattle. And all of them have some form of shared decision-making in their interventional plans. So think about shared decision-making. How can you bring that in where you are? Or how can you build it into a workflow? Just look at that, think about it, learn about it, and see what you can do where you are.
Thank you. And yeah,
We
go
do
ahead.
have another question that's just come into chat from Jacqueline Burgess Bishop. You're welcome to unmute yourself if you like to expand on it. But what you are saying in chat is, moving forward to change the trajectory of kidney disease that has an impact at the patient level, what primary recommendation would you have for boards and senior leadership of healthcare organizations? And that was directed to Dr. Wyatt.
Yeah, so, and thank you for the question because it's essential. And this is probably a question I wrestle with on a daily basis. Who owns this? And when I was at Cook County Health System, part of this work was built into the dashboard that I presented to the Cook County Health System board and executive team monthly. So when we looked at the populations based on our data, they knew where we were. They knew the interventions. That's a system that was at the time cash strapped. But if I give an example just of the diabetes population, we knew we weren't doing a good enough job with retinal examinations. That based on the data, the board approved with our recommendation to go out and get retinal cameras to improve compliance with retinal eye exams. So look inside your system, and the boards and the executive teams and leadership writ large has to own this. What I call mainlining their own accountability, or another way we put it, the board, the executive team's leadership has to put skin in the game. That's what this is about. Wherever you can find that. So that's where I would start with them. The board, the leadership teams cannot be excluded from this. Information needs to be shared until it hurts. So that's what we call vulnerable transparency about what we're trying to accomplish, how and why.
I love that. Shared until it hurts. I'm writing that down. So I was just wondering, I put the question into chat. Is anybody on this call, and Deborah, I was thinking about you, but certainly any attendee, working with community programs that incorporate patient self-advocacy support? If you are, we'd love to hear about them. So put them into chat.
Jane, can I jump in here? This is Maureen.
Yes, of course.
So I'm from the other side, right? In this regard, I am not a medical doctor. I am somebody that's gone through this from the patient side. I was diagnosed because my primary care person just said, labs haven't been done for a while. Let's do some labs. And that's how my problems, she said, this does not look right. You're going to see a nephrologist. And for everybody who's listening, I want to point out that, while we do talk a lot about diabetes too, and so on and so forth, I do not have diabetes. I do not have hypertension. I'm one of those folks that has a genetic form of chronic kidney disease, and none of those are indicative of chronic kidney disease. That nothing that I had would have suggested I had kidney disease. I was at a healthy weight. I didn't smoke. I didn't drink. I ate a healthy diet. I exercised. I mean, I used to compete in bodybuilding shows, right? And eating a healthy diet, not taking any weird, strange, fake supplements at all. And it was only through a blood test. So even for those of us who don't have diabetes, who haven't been diagnosed, really make sure that those labs get done, and advocate for yourself that those labs get done on a regular basis. Mine was so advanced that as soon as I saw the nephrologist, I was on the list. I didn't go through, stage 1 and stage 2 and stage 3 with any care. I just went through it all on my own, wondering, why the heck do I always feel so dang tired? And eventually it was diagnosed. And so we have to remind people that just because you don't have those things doesn't mean you can't have CKD or end-stage renal disease, because I was almost to that point when I was diagnosed. So I wanted to jump in there, and I wanted to encourage everybody to just advocate for themselves, even if they don't fall into the normal risk factors. So there's also that. And I would love to be part of an advocacy panel for a local health system or for what have you. And I haven't been invited to do that yet. And if I can help in some way, anybody that's out there looking for someone, you know, on my side of things, as, you know, somebody interested in public health, and we're all about prevention. And so anybody interested in prevention in a way that someone with not only, you know, chronic kidney disease, end-stage renal disease, transplantation, but also you know, someone with a PhD in business, mine is not in public health, I have a PhD in business, strategic management, but also then I am a professor of public health. I am willing to, you know, share ideas and thoughts and whatever with whomever's interested in hearing from someone who's been through it, but also then has, you know, the ability to step back and look at it from a business standpoint and so on. So just volunteering my help.
That's right. I'm gonna jump in on that and just say this. And I'll come from my perspective of people here in Alabama, Black and brown people, and at Cook County, Black and brown people, and even at Cook County, people that first language was Polish.
Yeah.
They are afraid to do what you just said.
Yeah.
Right. So who's going to speak for them when they're afraid?
Right.
Right. And there's an attitude, and I won't name the place, they call it exceptionalism. And when I tried to understand what that meant, it's meant that we can treat these people any kind of way because they have nowhere else to go.
That's right.
Okay. So that becomes that reality of it, that there are people who are afraid to ask questions.
Yes.
Because they have nowhere else to go.
That's right.
They are afraid to ask questions because the physician may say, "Where'd you get your medical degree?"
Right.
Right.
Absolutely.
So then I'm pointing my finger right back at my profession because I've earned the right to do so. Mm-hmm. And until, again, leadership and clinical leadership says, don't put the entire onus of this on people who are afraid of you.
Yeah. Well, and that's why I feel I need to step up, because I can represent people who are afraid of you, because I'm not afraid of you at all, because I have every right to question and get my questions answered. And if there are other people afraid to do that, give me your questions and I will ask them. You know, so we need people to be patient advocates, you know, and I think someone that's been through it, not someone who's officially assigned by the hospital, you know, so the social workers play the role of patient advocate, but somebody who's been through it, I think can make a better patient advocate than someone who knows it intellectually, personally.
Well, thank you all. This has been fantastic. And once again, we've gone over from where we thought we would be when we wrapped up. So this is our call to action. Michael, do you want to take it from here?
Sure. We have a call to action to commit to doing just one thing to help close health equity gaps in earlier diagnosis of CKD. First one is reinforcing what Dr. Wyatt said, and that is to listen to your patients with empathy and establish shared decision-making when incorporating screening and assessment protocols for your at-risk patients. That will enable you to help identify health inequities and disparities. We encourage you to stay up to date on CKD risk factors and the most current screening and treatment guidelines for eligible patients, ordering the screening test, or to start the proper medications to mitigate the progression of CKD for those disproportionately burdened, or facilitate a partnership or staffing opportunity to ensure social determinant of health screening to identify needs and get them addressed. And then for those non-clinicians and community-based organizations, we encourage you to develop multi-sector partnerships and collaborate on evidence-based education and interventions within the community. Advocate to policymakers to reduce healthcare inequities among those with or at risk of developing CKD, and collaborate with your community partners to address social determinants of health. Next slide, please. Just a reminder, Telligent offers no-cost technical assistance tailored to specific quality improvement challenges, comprised of providing evidence-based QI principles and tools, evidence-based practices. We also work on clinical guidelines and share those, as well as develop change pathways. We have an excellent patient and family engagement component to our work, as well as providing community and provider data. We also have two upcoming events that we want to share. One is Chronic Disease Management and Preventive Services Learning and Action Series. This series is produced in collaboration with Medicare administrative contractors. So we encourage you to take a look at what we offer in terms of Medicare billing requirements for preventive visits and screening services. In particular, we'll be focusing in on annual wellness visits, and that's on tomorrow's presentation. We also have a roundtable event with our Medicare administrative contractors, spotlighting a practice who does a high volume of annual wellness visits for their Medicare fee-for-service patient population. Next slide. Again, today's presentation slides, recording, and resource and action guide will be emailed to all registrants. If you have questions, need help, please let us know. In the link shared in chat, we're here to help you. And we encourage you to enroll in Telligent QIs Connect during the enrollment period that will last for the next several months. Finally, we just want to thank our subject matter panel for sharing their expertise, and of course to Jane for moderating the panel. I want to thank you who attended today. Your presence demonstrates your commitment to be a champion in slowing the progression of chronic kidney disease in vulnerable populations, and of course stopping racism. So this concludes today's learning session. Have a great rest of the week as you take what you've learned today to improve people's lives. Thank you.
Thanks, everybody.
Bye, everybody.